Hello everyone, this is Arije Docas from Group SWML13, and I'll be taking you through our project titled Supervised Tree-Based Architecture for Predicting Anti-Malarial Treatment Failure in HIV Co-infected Patients. In this project, we use the keywords of the anti-malarial treatment failure, clinical staging, HIV malaria co-infection, pseudo-label propagation, semi-supervised learning, tabular classification. The contents, we have the introduction, related work, problem statement, research questions and objectives, research contributions, system architecture, dataset description, model selection, results, model compression, and conclusions. I'll begin the background and introduction. So in Uganda, we have the co-infection with malaria and HIV remains a major public health challenge. Patients living with HIV often experience weakened immune systems, making them more vulnerable to severe malaria infections and increased treatment failure. Our project focuses on building a predictive risk scoring system capable of determining a patient's World Health Organization clinical staging using physiological biomarkers such as cluster of differentiation 4 count and hemoglobin levels. A major challenge in this work was nearly 75% of our dataset lacked labels. In other words, most patient records did not contain confirmed World Health Organization clinical stage information. Traditional supervised learning approaches struggle in such conditions because they depend heavily on fully labeled datasets. To address this challenge, we implemented semi-supervised learning using iterative pseudo-label propagation. This technique allows the model to learn from both labeled and unlabeled patient records, improving predictive performance even with limited annotated data. So we selected tree-based ensemble approaches instead of deep learning because our dataset is tabular, relatively small, and requires interpretability for the clinical use. Additionally, the system is optimized for low compute environments since many health facilities in Uganda lack high-performance computing infrastructure. Previous studies confirm that HIV significantly worsens malaria outcomes. In particular, reduced cluster of differentiation 4 counts, which indicate weakened immunity, are strongly associated with increased anti-malaria treatment failure. The two most commonly used artemisinin-based combination therapy drugs are the artemether, lumefantrine, and dihydroartemisinin piperaquine. Research shows that dihydroartemisinin piperaquine generally demonstrates lower rates of late treatment failure. However, treatment becomes more complicated when combined with the antiretroviral therapy used for HIV management. For example, protease inhibitors can increase lumefantrine exposure, while efavirenz may reduce it. These interactions may lead to reduced treatment effectiveness or toxicity. This issue is especially important in Uganda's rural regions, where both malaria and HIV virus prevalence remain high. The primary machine learning challenge addressed in this project is the severe label sparsity, where approximately 75% of labels are missing. This creates a significant mathematical and clinical problem. Simple imputation techniques, such as replacing missing values with average or medians, can distort the natural distribution of the patient data. Once the dataset becomes officially uniform, methods such as the principal component analysis and the pseudo-label propagation may incorrectly classify high-risk patients into average risk groups. Such misclassification is clinically dangerous because it may hide the vulnerable patients who require the urgent intervention. To solve this problem, we applied Miss Forrest a multivariate iterative imputation method before dimensionality reduction. This approach preserves the natural relationships within the data and minimizes the propagation of the systematic bias throughout the predictive pipeline. Our study focused on 4 key objectives. First, to determine the relationship between the cluster of differentiation for count and anti-malarial treatment failure risk. Second, to identify which artemisinin-based combination therapy drug performs better under different human immunodeficiency virus immune conditions. Third, to map geographic regions where HIV virus prevalence overlaps with anti-malarial drug resistance. And fourth, to investigate whether immunocompromised patients require faster escalation to alternative treatment strategies. This work produced 4 major contributions. First, we developed a predictive treatment failure risk score linking cluster of differentiation 4 levels with the resistance indicators. Second, we designed a drug effectiveness mapping framework showing which artemisinin-based combination therapies maintain higher parasite clearance rates among the human immunodeficiency virus positive patients. Third, we generated the geographic risk maps combining HIV prevalence data with sulfadoxine, pyrimethamine, and peparaquine resistance trends. Finally, we proposed a clinical decision support system intended to assist clinicians in selecting the most appropriate treatment option more effectively. This diagram illustrates the overall system workflow, beginning with the raw clinical data, followed by the preprocessing, imputation, pseudolabel propagation, model training, and finally deployment within the clinical interface. Each stage was carefully designed to preserve data integrity, reduce bias, and ensure reliable prediction outcomes. Our dataset consists of the hematological biomarkers, including cluster of differentiation for count, hemoglobin levels, white blood cell count, and platelet count. Because 75% of the dataset was unlabeled, we implemented a ground truth-only test split strategy to avoid confirmation bias. This means that only physician-verified patient records were used for final evaluation. As a result, the reported model performance reflects genuine clinical reliability rather than self-generated predictions. Here we look at the 12 models trained output results. We have the label propagation. This spreads through a graph based on similarity using a semi-supervised approach. We have the self-training XGBoost. Iteratively trains XGBoost on labeled data, then adds high confidence predictions to the training set. We have the label spreading. This is similar to label propagation, but more robust to noise using normalized graph Laplacian. We have the self-training with the Gaussian process classifier. This one uses the Gaussian process uncertainty estimates to selectively add pseudo-labeled data. Then we have the Gaussian process regression, non-parametric regression providing mean predictions and uncertainty using kernel functions. We have the XG boosting plus sharp values. This builds gradient-boosted trees and explains predictions via sharply addictive explanations. We have the co-training. This trains two views, feature splits on labeled data, then each labels the other most confident unlabeled examples. We have the tree training. This uses 3 classifiers. If 2 agree on unlabeled example, it's pseudo-labeled for the third. We have the Bayesian hierarchy. This multi-level Bayesian model sharing statistical strength across groups or tasks. We have the transductive vector support machine, SVM variant that optimizes directly for enabled test data, transductive learning. We have the Laplacian visualized least squares. This adds graph-based Laplacian visualization to at least squares for semi-supervised regression. We have the elastic net architecture, training and audit near model with L1 plus L2 visualization plus structured training and validation checks. These are the results for the 12 models that were trained. Then here next we go to the model selection and deployment. We selected the self-training Gaussian process classifier and as the final deployment model because it achieved the highest overall classification performance. The model supports semi-supervised learning naturally. It handles uncertainty estimation effectively and produces well-calibrated probabilistic predictions, all of which are essential in the medical applications. This is the model of the selected, this is the architecture of the selected model. So to improve transparency and interpretability, we incorporated sharply addictive explanations and permutation importance techniques. These methods allow clinicians to understand which biomarkers contributed most strongly to each prediction. This slide presents the explainable AI audit. So we shall begin with the sharp global feature importance for the self-training XGBoost. Here, the country ID is the most influential feature, followed by the co-resistance status, country, and study ID. This means geographic and resistance-related factors contributed most strongly to the model's predictions. Next, we have the Lyme local explanation showing why a specific isolate was predicted as active. Green bars represent features supporting the prediction, while red bars oppose it. This demonstrates that the model is not making random decisions. It is weighing biologically meaningful variables differently for each case. The permutation feature importance for label propagation. Here, the permutation feature importance validates these findings independently. Again, coresistance and country-related variables rank highest, confirming consistency across interpretability methods. Then here we have the global feature importance. The feature importance comparison highlights how metadata such as the drug type, geographic coordinates, year, and study duration affect predictions differently between resistant and susceptible classes. The bottom, middle, and the right panels show the average and single instance Lyme explanations for the tri-training and co-training models. These visualizations help us understand feature influence at both population level and individual prediction level. Our interface has 3 parts. The single prediction. This one requires us to enter feature values manually, which will take a lot of time since we have large data sets. So we opt for the batch prediction, whereby we shall enter a clean data set and run the batch prediction, and also the model evaluation, whereby we shall evaluate the model on a labeled data set to get the performance metrics. In demonstration of the developed product, we developed a Streamlit-based web application containing 3 main sections: a single prediction, batch prediction, and model evaluation. A clinician enters patient biomarker values into the system and receives a prediction indicating whether the case is classified as active or not active, together with a confidence score. If the prediction confidence falls below 75%, the system automatically flags the case for additional clinician review. The deployment package contains 3 primary assets: the self-training Gaussian process classifier model, the standard scaler and the feature schema used for preprocessing consistency. Model compression. Since the target deployment environments include resource-constrained clinics, we implemented model compression techniques to reduce the computational requirements. The original model was approximately 3.2 megabytes. Knowledge distillation, where a smaller student model learns from a larger teacher model. We reduced the model size to approximately 1.2 kilobytes, while maintaining the same accuracy and F1 score. Pruning removed less significant features, reducing the model size to 3.08 megabytes. Quantization converted model weights from 64-bit floating point representation to 32-bit floating point representation, improving inference speed with minimal effect on the model size. So among these methods, knowledge distillation provided the best deployment efficiency. These are the model compression visualizations. Then one limitation of this study is the possibility of bias within the initial labeled dataset. If the region of 25% labeled records do not fully represent the broader patient population, pseudo-label propagation may unintentionally amplify those biases. To improve transparency and reproducibility, we intend to open sources of all scripts, enforce deterministic evaluation procedures, and fix random seeds for external clinical auditing. In conclusion, this work reframes anti-malarial treatment failure prediction as a rigorous and supervised learning problem while addressing real-world challenges such as label scarcity, interpretability, and raw resource deployment. For future work, we plan to validate the system using larger global datasets collected between the 2021 and 2024. We also intend to integrate genomic resistance markers related to piperaquine and sulfadoxine pyrimethamine resistance and expand the semi-supervised framework to utilize even larger enabled clinical datasets. Finally, we recommend insights from this work contribute toward strengthening Uganda's public health treatment guidelines. Thank you.